All right. Yeah, this should be quick. We're all hungry. So, unfortunately, there's a lot of slides of surgery. So, some of you are going to lose your appetite. But I'm always asked to give this talk because, mitral valve surgery, intervention on the mitral valve is still a state of flux as to when to refer these patients for surgery. So I'm asked to do it again and talk about new stuff. So, haven't we heard this before? Yes, we have. And we're going to hear it again, and we're going to hear it again, and we're going to hear it again until everyone understands that early referral and early intervention is the only way to optimize outcomes with surgery for the mitral valve. So our lecture objectives today are the same as always, learning and understanding the guidelines for treatment and exploring contemporary therapies for the repair of the mitral valve. Disclosures. These were disclosures, but it's been a soft year for me. Okay, I'm trying to figure this out. Just give me a minute. We'll get back on the train here. Structural heart disease encompasses so many different pathologies and parts of the heart. And yes, I did include atrial fibrillation on there because atrial fibrillation is a structural disease, as you heard in the previous speaker. But today we're just going to concentrate on the mitral valve regurgitation, something that I love to do, and I've dedicated a significant part of my life to it. Mitral valve disease. So let's start with the anatomy. You always have to know what's happening to the heart. And the mitral valve apparatus is comprised of 5 different components. So when you're operating on the mitral valve, you have to operate on all 5 of these components, or the repair will fall apart. And this little movie here, we saw this before. I love this movie. So here are all the components of the mitral valve: the anterior leaflet, the posterior leaflet. And as you see, the leaflets are attached to the papillary muscles by the tendinous cords. And you have the left atrial wall and the left ventricular wall as well, all working in concert. Now, I was in New York not very long ago and had a chance to go to the Statue of Liberty and saw the original French plaque that accompanied the statue. And the translation, give me your tired, your poor, and your huddled masses, yearning to be free of mitral regurgitation. This going to breathe free can, kind of be interpreted as getting rid of mitral valve regurgitation. But the French have always played an important role in the development of techniques. And we'll talk about Dr. Carpentier later. Now, mitral valve regurgitation is divided into 2 different types. You have your primary or degenerative, which is usually caused by some sort of abnormality in one of those 5 components of the mitral valve apparatus, most commonly being mitral valve prolapse. And you have secondary mitral valve regurgitation, which is usually due to ischemic cardiomyopathy and annular dilatation. Now, going back to my little movie, this is a degenerative disease, and this is what happens over time. The cords start to elongate, and they elongate to the point where they rupture, and you have a flail posterior segment of the mitral valve, which leads to mitral valve regurgitation. This chart has been in my talks for the past 20 some odd years. This particular schematic is almost 20 years old. So we knew this data 20 years ago. And I'm not going to try to read it because it's too far away. But as you can see, all roads lead to some form of repair. So you have to understand these patients progress, and they progress sometimes quite rapidly. So the importance to get them into a structural heart program for follow-up and sometimes urgent early intervention is the only way to treat these patients. So watchful waiting, which is something that a lot of people still employ, even in 2024. But the only patient that you can watchfully wait is someone with mild MR with no symptoms. Otherwise, they need to be referred to a heart team to order the appropriate testing and get these patients fixed early. And, clipping ain't easy. So we're going to talk about that a little bit later. Now, the effect of watchful waiting is well documented in a now 30-year-old Mayo Clinic study that looked at who did better. Patients who came in, multiple symptoms, left ventricular dysfunction, dilated left ventricles, AFib, are those that walked in saying, "What am I here for?" And it clearly showed that a normal heart has a better survival outcome. I mean, it's kind of, intuitive. And of course, no surgery talk would be a surgery talk without a Kaplan-Meier curve. And all this does is show what the original slide showed, that 70% of people are still alive 10 years out once they were operated on with a normal heart. Oops. We're not advancing. We're stuck. Okay, so you'll have to do it then. So what's new? Traditionally, the mitral valve was repaired with something called resectional valvuloplasty, where you went in and you cut out the bad part and sewed it back together, and then put a stabilizing annuloplasty ring on there. Some believe that doing that changes the ventricular geometry and can lead to reduction in left ventricular function as well. So leaflet preservation is the quote unquote new way of approaching the mitral valve. It's a little movie that sort of illustrates triangular resection, where you go in and you make a little triangular cut out the bad part, sew the new part together with tension-free anastomosis, and stabilize it with a ring. And that's the way mitral valve surgery has been done for the past now almost 40 years. Now it's moving too fast. Now we're using what's called the pre-measured loops, where the ruptured portion of the valve is reattached to its corresponding papillary muscle by a cord that is measured against a normal cord. And that's how we started doing leaflet preservation approximately 15 years ago. And this is sort of how I used to do it in the OR. Now we have machine-derived pre-measured loops, but you can use retractors in the OR and just measure out a loop, compare it to the normal cord, and sew it to the mitral valve. And the data sort of supports preservation, where you have a not clinically significant, but there is been shown to have some improvement on survival by preserving all of the mitral valve apparatus. But there is clinical significance at the durability of the repair if you preserve the entire mitral valve apparatus versus resecting it and putting it back together. So this is a posterior leaflet prolapse that we did here at the Heart Hospital. You can see, hey, go back. You can see the large regurgitant jet. Here, I'm measuring the valve. I'm looking for the normal chords to sort of get a measurement on, so I can know what length of cord to use for the repair. This is my Zen. I do a little test insufflation of the ventricle. I could do that for hours. It probably takes me an hour to do the case, but another 20 minutes doing this. It's just great. And then here are the pre-measured loops of the Gore-Tex cords, reattaching that partial flail mitral valve leaflet, and of course testing it again. I don't have to put this in there, but I just like watching it, and showing you now a competent mitral valve. And of course I'm going to do it again, because that's what we do. That's just what I do. It's my thing. It's my jam. But you see a now competent mitral valve. And post-procedural echo shows no leak. And that's the mitral valve being profane. Um, on the left there, and then on the right you have a competent mitral valve, and there's the eye of God view that measures for mitral valve stenosis to make sure we didn't tighten it too much. So what else is new? What else is going on? What's happening? Well, because the data is so good on repair, it is being advocated that the mitral valve be repaired for everything. And the replacement be only reserved for those that can't be repaired. And that includes everything: anterior leaflet repair, bileaflet repair, trauma, all these things that heretofore were only treated with replacement are now being treated with repair. And that includes Barlow's, which is a funny story, which I'll get into later. So anterior versus posterior leaflet, the data is showing that it's exactly the same with repair versus replacement. Historically, again, it was treated with replacement because people thought that the repair was not reliable, it wasn't durable. But recent stuff is showing that it's good. And in the right hands, mitral valve repair is far superior to replacement. In fact, the powers that be have all established a directive to structural heart teams to consider repair for everything, and use your due diligence when it comes to selecting the appropriate treatment modality. And there's a heart team. That's us on Friday. We sit around and talk about the patients, trying to figure out the right piece of the puzzle. And, of course, the surgeon has the right piece of the puzzle. I don't know what the guy with the blue piece is even thinking about. It's probably Dr. Kunz. So anterior leaflet repair did this case a couple months ago. Let the movie begin. So there's a pretty gnarly looking anterior leaflet. And on 3D, you can see that jet is pretty complex. And then post-procedural, we have a fully repaired valve. And there's your eye God view. I'm not sure what's happening with the thing there. Bileaflet pathology is very complex. I mean, it scares some surgeons when it comes to doing repair, because you have to be able to do everything to try to fix a bileaflet repair. And it's very technically demanding. So that's why in years past, it was advocated simply to replace the valve and get the patient out of the operating room. But again, recent studies are showing that repair is superior for survival, quality of life, and durability. And early surgery, I've been hammering that home, is the best way to get the best results. Here's a bileaflet prolapse that we did a month ago in a patient. Very complex, ugly, gnarly mitral valve grooves and jet. And that's after we fix it. Now, Barlow's disease is a special animal, something that is truly scary for a heart surgeon, because it is a very complex pathologic entity with multiple different issues involving that valve. And successful and durable repair is always a challenge. You have to have a command of all the different types of ways of treating the mitral valve. And replacement is still an option in people who are less skilled in mitral valve repair, or in patients who simply have the anatomy that precludes it. And again, recent studies are showing excellent outcomes. And Carpentier took this personal. And it's a funny story. Carpentier and his wife developed an institute devoted only to mitral valve repair. And he felt that the only people who could do a Barlow's valve are people he personally trained. So he developed a sort of club. It was called Le Club Mitral, where invited people, surgeons from all the world, came over to learn how to do mitral valve. And for some reason, I was there. I don't know. Maybe I was getting coffee. I have no idea. Just walking down the shafts and got pulled in. But they showed us how to do all this complex mitral valve surgery. And someone raised their hand and said, Dr. Carpentier, what about Barlow's? And he said, oh, no, you can't do Barlow's. Only my personal trainees can do Barlow's. You replace that valve. And I was like, wow, I was 2 years out of fellowship. And I was like, well, I guess I won't be repairing any Barlow's around here. But, Carpentier, this one's for you. This is a Barlow's valve that we repaired about 2 months ago. Very, again, gnarly jet, just an ugly valve. It actually had a little bit of pathology on both leaflets. It was a billowy anterior and a restricted posterior. Initially, I said, okay, I'm just going to cut this thing out. But our anesthesiologist said, what are you, wimp? Get it, do anything. So we went on and fixed it. And that's the result. That was a very great case. And of course, it has good opening. I think the mean gradient was 1 on this valve. Acute chordal rupture, as we all know, those patients are tremendously sick, and you just really want to get in and get out. So, the school of thought on repairing these valves really deals with surgeon comfort. So these patients are usually in shock, and even if you do the perfect operation, they're still at 20% mortality rate 30 days post-op. And if it's a ischemic etiology, it's even worse. So in younger patients, people think it's preferred because it removes the need for Coumadin with a mechanical valve. And again, if the surgeon is uncomfortable, replacement is a good option. But it should be attempted if you're trained to do it. And so yeah, here's a patient, acute chordal rupture just last week. Came in and we the posterior leaflet just kind of giving you the finger, and so we repaired that as well. If it plays, it plays. If it doesn't, it doesn't. Oh, look at that! I think we're in a black hole. So take-home messages today, as always. Structural heart is prevalent. It's increasing. We need to get to these patients early. It takes a village. We need team efforts. Technologies are advancing in order to address all of these different types of modalities and different type of problems. And collaboration between you guys and us with early referrals and earlier interventions are the ways to get these patients through and over their disease. As I always do with most of my talks, I didn't do it in the beginning, but I always leave a little wisdom throughout my years and our future.